Good afternoon, everyone, and thank you for joining us for the Overdose Prevention Engagement Network webinar. Welcome to today's session, Breaking the Barriers, Addressing Stigma and the Path to Recovery. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work, CE, and McBath credits for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We will also email the continuing education credit information to everyone after the webinar today. My name is Katrina Hernandez. I am the engagement specialist with OPEN, the Overdose Prevention Engagement Network, and I will be moderating the webinar today. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative, evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain and can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and McBath credits, and for prescribers, all of our credits also qualify for the DEA-required SUD training. We provide MOUD training for physicians, and this year we are incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all these services more directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a full library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants. And we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. For overdose rescue support, we fund implementation of naloxone vending machine and distribution boxes and naloxone administration trainings. These trainings are offered as live, virtual, or free online training courses. No planners, faculty, or others in control of content, either individually or as a group, have relevant financial relationships with ineligible companies. Our presenter today is Dr. Alec Ellswick, who is a tireless advocate for people with substance use disorders. He currently serves at the University of Kentucky as the Assistant Professor and Extension Specialist for Substance Use Prevention and Recovery. Alex is a trained researcher, recovery coach, and mental health therapist, as well as the co-founder of Voices of Hope, a peer-driven recovery community organization. But most importantly, Alex is himself a person in long-term recovery from the chronic disease of addiction. And with that, I will turn it over to you.
I'm so glad to have the opportunity to be with you and to talk about something that I've had the opportunity to experience, stigma from the perspective of personal experience as a person in recovery, stigma from the perspective of seeing the way that my family members and loved ones were stigmatized from, as a co-founder of a recovery community organization, we staff 85 people who are all in recovery. And most of whom are kind of in that precarious early recovery stage, and who experience a tremendous amount of stigma because of their dual roles as a peer professional. Um, so I'm just glad for the opportunity to share about all these things, and I wanted to say thank you to Katrina and the whole team. I get to do a tremendous amount of public speaking and presenting, and sometimes I think I take for granted what an opportunity it is to be given a platform, and to have my voice amplified and to have hundreds of people who are willing to show up and listen. So thank you for the work that you all have done. And sincerely, thank you to all of you who have jumped on here, however you're joining, if you're eating lunch or whatever it is. I'm just glad to have you listening. I am a person who has had the opportunity, the really fortunate opportunity to learn about drugs and people who use drugs from a tremendous amount of different experiences, really eclectic experiences. So I have clinical experience as a marriage and family therapist. I am a researcher. Most of my research focuses on, more recently, on evidence-based harm reduction interventions. I am the co-founder of Voices of Hope, which is a recovery community organization. And so really briefly, I'll just mention, in case you're not familiar, we're not a treatment center. We're not a residential center. We're a community center for people who use drugs and people with substance use disorders. So we're like the hub of long-term recovery support for a chronic disorder like addiction in our community. So housing, education, employment, transportation, mental health services, certainly access to evidence-based treatments, all the things, sober social activities, meetings of every stripe. One thing that I didn't have the opportunity to build into this presentation because we just don't have the time is to talk about stigma against various pathways of recovery, which is something that we take really seriously. What's part of our ethos at Voices of Hope, that we support all pathways of recovery. And we recognize that straightforward abstinence or abstinence informed by 12 steps is certainly one valid pathway of recovery, but it's by no means the only valid pathway. And we're really ardent supporters of other pathways. So maybe we'll have the chance to touch on that a little bit, but and so, it's kind of a wealth of experience. You learn different things from research than you do from the on-the-ground service provision, and you learn different things from the service provision than you do from clinical work. But I always tell people that without a doubt, the most important experience I have is personal experience, because I'm a person in recovery from an opioid use disorder, a person who's been justice involved, a person who's experienced homelessness. And just in the interest, since we're talking about stigma, I share my story, or at least a little bit of my experience, basically every time I have the opportunity. And when I first got into academia, I stopped doing that because I didn't want to be stigmatized, and I didn't want to be treated as just like the tokenized guy in recovery. I wanted to have the credibility of an academic like anybody else. And so I say that to say there was this period of maybe a year or two where I stopped telling my story, and I saw before my eyes the impact that I was losing. And it just reminded me that evidence shows, and we'll touch on this later on as well, that research shows that actually the single most effective strategy to reduce stigma associated with substance use disorder are contact-based strategies, which is a fancy way of referring to what I'm doing now, sharing some personal experience, having a positive interaction with someone with a substance use disorder or someone in recovery, right? So what I want to do is share a little bit of that personal experience and then kind of give a deep dive into what is stigma. What do we mean when we talk about stigma? We know it's something bad, but sometimes it's a little bit ambiguous and amorphous. So we're going to nail it down, kind of give you a sense of the scope of the problem. And then we'll talk about some of the evidence-based strategies for combating stigma. And whether that be as an organization, as an advocate, or even as an individual within a professional work environment. So as I said, I cannot, I'd be remiss if I didn't share some personal experience. I know we're pretty short on time today, so I'll try to truncate this a little bit, but I've been alive for 34 years, so it's hard to nail it all down into, 5 minutes, but I never know which part of this story I'm going to share. But I always start in exactly the same place, and that's by telling folks that I grew up immensely privileged. And I don't do that to virtue signal or anything like that. I do it because it's true. My dad's a doctor. My mom's an accountant. I grew up in the suburbs. I went to private school. Nothing bad ever happened to me when I was a kid. I wasn't neglected. I wasn't abused. My parents didn't use drugs. My dad never drinks alcohol, just doesn't have an appetite for it. And my mom, if she so much as has like a second glass, she'll have a glass of wine on a Friday night. And if she even considers having a second glass of wine, she thinks she's living life on the edge, you know? And so I say that to say I come from these wonderfully responsible parents, really a protective environment. But he couldn't change the fact that I inherited risk factors for substance use disorder that, unbeknownst to me at the time as an ignorant adolescent, and risk factors that I didn't choose for myself. And so the first is a genetic predisposition. There's immense amount of addiction in my extended family. I didn't know that when I was 13, but when I was 26, it was really easy to look at the research and see that my risk of developing an SUD was elevated relative to all my peers before I ever made a bad decision. And one of the things, stigma is associated with perception of blame. So if you think that a person is to blame for their substance use disorder, you're more likely to stigmatize it, right? Um, and uh, and yet, so much of that was beyond my control. And then, secondly, from the time that I was young, I've struggled with anxiety, and I've been diagnosed with 3 different anxiety disorders. So, generalized anxiety disorder, social anxiety disorder, and trichotillomania. For anybody who doesn't have a clinical background, trichotillomania, I believe in the DSM-5, in the Diagnostic and Statistical Manual, that it's organized with anxiety disorders, but it's a hair pulling disorder, and it disproportionately affects adolescent females. So usually you see like 12 or 14-year-old girls coping with anxiety in a sort of maladaptive way where they start playing with their hair and pulling out clumps of hair, and it becomes distressing and embarrassing. And I don't know why, and you're welcome to ask whatever questions you'd like at the end of this, but don't ask me why my eyebrows, because I don't have a good answer. All I know to tell you is, let me get a good pen here. I'm right-handed. And so when I was in school, my left hand would creep up to my eyebrows and just pull and pull and pull. And I mean, until I had no eyebrows. All right. And it probably goes without saying that I wasn't doing that volitionally, intentionally. I wasn't doing that willfully. I promise you, I didn't wake up on a Tuesday morning and say, you know what, all the 7th grade girls are going to think is super cute is if my face is bald. Um, and and part of the reason I mentioned that, I know you all are all educated clinicians and providers, and you're well aware that there's this comorbid relationship between substance use disorder and co-occurring mental health disorders, anxiety, depression, et cetera, et cetera. But there's kind of a more meaningful connection I want to make here. And that is, if you all can remember those hard plastic chairs you sat on in middle school that have the 3 little slits at the back, I have a very vivid memory of being in like 8th grade and sitting on my hands, physically sitting on my hands on those chairs and saying to myself out loud, Alex, stop. And for like 30 seconds, I could clench my fists and I could grit my teeth, and just sheer willpower alone, I could force myself to stop, but not for long enough, because as soon as I relaxed or went back to focusing on work, I'd start plucking away again. And the reason I mention that is because there was no amount of willpower that I could muster that was enough for me to overcome a disorder like trichotillomania. And it's so analogous to what it was like for me to be 23 years old, to be addicted to Oxycontin or heroin, and have everyone around me telling me, you just need to stop. If you really want to stop, you'll just stop. You just need to stop. And I am telling you all, I had no more willpower um, over my ability to stop using at that point than I did over my ability to stop pulling eyebrows out. It's so similar. Um, I just know what it's like to act against my own will. And so this is you can laugh at all these, it won't hurt my feelings. This is like 17-year-old me. I thought I was real gangster for a while, so that's what that is. When I was 18 years old, I'm going to move this along for the sake of time. When I was 18 years old, I got the chance to go play college baseball, and I had surgery to have my wisdom teeth removed, and I got prescribed oxycodone. And I took it exactly as it was prescribed by my provider. But it didn't matter because I have all these risk factors and red flags. And so I developed an opioid use disorder. And for the sake of time, I'll just tell you that addiction took me all the bad places that people go. I went in and out of treatment. I went in and out of jail. And I would say this, there's so much that I always want to communicate when I share my own experience. But the one thing I want to communicate the most, especially to providers, is I was trying so hard to stop. And that's There's probably a more eloquent way to say that, but I'm telling you, I was trying so hard to stop, and yet what we're talking about is limbic, right? We're not going to do brain science today, but what we're talking about is survival circuitry. And that's not something that willpower is enough to overcome. Or at least it wasn't for me. I wasn't strong enough, however you want to couch that. And so I ended up, after like a 7th treatment center and a 7th relapse, I ended up experiencing homelessness in 4 different in Nashville and Lexington and Cincinnati, and finally in Dayton, Ohio. This is Highway 35 overpass that runs through downtown Dayton. And I met a community of folks there who were IV drug users who showed me where to go to get a meal and where to go to get a shower. And they told me about a Salvation Army. So this is September 13th, 2013. It's the second time I checked into the Salvation Army because I got kicked out once for non-compliance, which is a term that I strongly dislike and find stigmatizing. And we can talk about that when we talk about language, if you're willing. But when I got back in, September 13th, it's the start of the worst 30 days of my entire life. And then really slowly things started to get better. I ended up spending 6 months at the Salvation Army. And when I got out, I had so much help. Because I faced all the barriers that are really characteristic barriers that people face when they leave treatment or incarceration, because I had bad credit and lots of debt and a criminal record and no college degree and no skills and all that kind of stuff. But what I had was access to recovery capital, I was privileged, however social determinants of health, whatever language you like to use. I had help with housing and with transportation and with employment and with education and with mental health and with all the ingredients that would make someone successful in sustainable recovery. And so I simply say that to say, I'm going to stop my story here and just say, I've been in recovery for 12 years, coming up on 12 years, and I get a lot of pats on the back that I don't deserve. Because people say, Alex, we're proud of you because you're strong and you're brave and you're resilient. And I wish that those things were true. They're awful kind things to say, but that's not true. That's not, that's so moralizing. That's so moralizing a chronic disorder. I'm not in recovery because I'm strong or resilient or brave. I gave up so many times. I relapsed so many times. I'm in recovery because I got access to what I needed. And in some ways, I think that's one really effective way to reduce stigma, is to, like, we do a really good job of remembering that addiction's a chronic disorder when people are developing their addiction. But then as soon as people are in recovery, it's like we forget that. And if they experience a relapse, providers act like it's just a simple choice. And that's problematic for so many reasons. But for the sake of time and for our focus on stigma, I want to get into so many other things. So really quickly, that's my mom and dad. Every Wednesday for the first like 18 months out of treatment, I met my mom and dad at the Waffle House at Awful Waffle, and we had breakfast. And it was like, this is neutral ground on which we reconnect really slowly, rebuild trust. Really important part of my recovery and my recovery capital as well. Zooming ahead here. So what the heck is stigma? We talk, on some level, it might seem really silly and maybe even offensive that I would begin a presentation like this by asking the question, what is stigma? But to be fair, a lot of us really don't know. We have this intuitive sense. We know it's something bad, but I think it's really helpful to kind of be specific. So for a definition, for a Merriam-Webster definition, stigma is a mark of disgrace associated with a particular circumstance, quality, or person. I was on a call last night with an advocate from the ACLU who has lived experience as a teenage parent. And she was talking about, what a stigmatizing experience it is to be a parent as a teenager. That's a perfect example of something that's been marked as disgraced. Irving Goffman, who's the father of kind of the literature on stigma, referred to a stigmatized identity as a spoiled identity. And more recently, researchers have used the language of socially discrediting, which I think in some ways is the most operational definition of what stigma is. That's what it does, in effect, is it discredits people socially. And I'm a nerd for words, and I think sometimes, tracing the etymology of a word gives you an even more profound understanding of its meaning. And the word stigma actually comes from the Greek stig or stigum, which refers to a tattoo or a brand. Because as far back as, Greek and Roman times, people who committed criminal offenses might be branded in order to readily identify them. People who were enslaved in the transatlantic slave trade were sometimes branded, right? That's with an R on their cheek if they tried to run away. That's a physical stigma. It's a physical mark of disgrace. Um, if you all read the Scarlet Letter, you were supposed to in high school. So if you didn't, you you overlooked an assignment, right? The Scarlet Letter is the protagonist commits adultery and she's forced to wear a scarlet A on her chest. And that is a physical stigma. It's this physical mark of disgrace that discredits her wherever she goes. Today, we don't brand people in order to stigmatize them. We don't tattoo them. We don't force them to wear, at least in most cases, we don't force them to physically identify like this. Um, and yet, stigma still exists on people. And so, even though in some ways, I compare it to racism. Racism 75 years ago was much more overt. Today, it's a little more subtle and covert, but exists nonetheless. That's kind of how stigma is over time. It's not an overt mark of disgrace, but it's sort of covert. It's sort of built into the identity. And it's important to recognize that substance use and substance use disorder aren't just a little bit stigmatized. In fact, they are the most stigmatized health conditions on the planet. So this is dated, but back in 2012, the World Health Organization um, studied this and researched, um, you know, HIV and STIs and every kind of stigmatizing condition you can think of, and found that illicit drug use disorders are the most stigmatized health condition, and alcohol use disorders are the fourth most stigmatized health condition. And what's even more problematic than that, than just the fact that stigma abounds, is who stigmatizes, which in short is everyone. If you all have had your provider implicit bias trainings or whatever it is, you've probably learned something to this effect, but none of us are immune. None of us are truly objective because we're all coming in with preconceived ideas about drugs and people who use them. So research shows that stigma is high among the general public. Perhaps no surprise there. They're not terribly educated on sort of neuroscience of addiction or what have you. But stigma is also high among professionals who interact with people with substance use disorders. And so that includes most of you all, to be frank, not to point fingers or anything, just to be frank. And it's even worth mentioning that stigma is high among people who use drugs themselves, both in the form of internalized stigma and shame, and also in terms of outward stigma towards one another, which is ironic and diabolical in so many ways, but has a lot to do with the way that we internalize stigma. And so I wanted to just start by sharing a few personal experiences that I've had with stigma in order to make it a little less abstract and a little bit more real life. So when I started at the University of Kentucky as a graduate student in 2015, I was green as can be. I was the least academically prepared of everyone in my cohort. I was so nervous and anxious and filled with imposter syndrome. And I still smoked cigarettes, and nobody smoked cigarettes on campus. For so many reasons, I was worried. And the weekend before I started my graduate work here, our nonprofit had been in the newspaper, and I promise I'm not mentioning that to be braggadocious. It's just part of the story. Then when I got on campus, one of the professors, not the professor I was working for, but another professor, had seen that article, and she brought it to the professor who I was TAing for. And she said, "Hey," I mean, I don't want to name names. She said, "Hey, Dr. So-and-so, have you seen this?" And then her subsequent question was, "Are you concerned for your safety?" All that the newspaper article was celebrating a recovery event that we were hosting. But that's a really good example of stigma. And part of what I want to describe to you is the effect that had. Because sometimes I think we misunderstand the effect. The effect was not for me to be cut down in that moment. When I heard that, I was probably a little bit bothered in the moment, a little bit hurt, but the real effect is death by 1,000 cuts. It's what comes next. It's now the anticipated stigma, the chip on my shoulder that I carry with me into every interaction. Because now every time I go on campus, I know that there are people like her who are kind, educated people, and yet people who hold incredibly stigmatizing views about someone like me. And it put me on the defensive. It meant I can't be sleepy in class. If my classmates are sleepy, it's because they were up late last night studying. If I'm sleepy, it must be because I've taken an opioid. Um, so it really inculcated me with a sense of anticipated stigma that this is what this experience is going to be like. And the reason that's worth mentioning, just to highlight, that means even if you, a provider, are a golden provider, and I mean this in the best way, even if you do everything right and you're non-judgmental and you're like harm reduction oriented and you build a therapeutic alliance, what you should know is, even despite your best efforts, the person you're encountering with a substance use disorder has probably already been stigmatized so many times before. If we have some time at the end, I'll share about some research we're doing right now where we've heard some of these in focus groups, and they're just appalling stories. Okay, example number two. When I got to UK, I wanted to learn as much as I could about addiction. I'm desperate to just learn as much as I can. And so I went into the course catalog and I typed in all the search terms, addiction, substance use disorder, all that kind of stuff. And I took every course I could in every department, reached out to department heads to get special permissions and all that kind of stuff. And I took a class in the College of Social Work. And it's the only class that social work students take that focuses on substance use. And the title of this course is it's Substance Misuse, Violence, and Risk Management, which on its face is obviously very reasonable because those are very important aspects of social work, no doubt. But the point I want to make here is that it means that the University of Kentucky, every single social work student that we graduate is graduating with an understanding of substance use only in the context of violence and risk management. And there is a relationship between substance use and violence, but it isn't nearly as robust as the general public and the media would have us believe, right? Much of that are exaggerated harms. Um, and so it's just an example of the way that stigma gets embedded into not just our language, but our programming. I just have serious concerns for how that impacts the the ability then of these social workers to go and form a non-judgmental therapeutic alliance with the patients that they have, the clients that they have. And then a final example, which is where I learned not the futility of fighting stigma, because it isn't futile, but the uphill battle that it is. I got invited this many years ago, 2017, to an event that's in Scott County, which is a rural community in Kentucky. And as you're probably aware, stigma abounds even in urban settings, but it tends to be a little bit exaggerated in rural communities. And it was certainly the case in this community. And I listened one after another after the sheriff and then the head of EMS and a doctor, a physician at the emergency department, each made a variety of really, really stigmatizing remarks, and kept talking about addicts and frequent flyers and just using really offensive language. And so I thought, this is my moment. And when I got the microphone, I stood up at this community forum and I was so excited to share with them a study that I'll share with you all in a minute that's about the importance of using destigmatized language. And I thought, look, we know we do better when we know better. And I thought, so these folks are going to know better and they're going to do better. And I'm going to solve probably the addiction crisis with this intervention, not to be too lofty, but I felt like I did a great job. Somebody sent me a congratulations the next morning because I was on the front page of the paper. And here's here's the headline: Ex-addict warns about narcotic problem, which is just replete with kind of very much stigmatizing, somewhat ambiguous terminology. Narcotic is very stigmatized. It's a little bit ambiguous. Ex-addict is stigmatizing. We'll talk about that. So obviously my my best attempt to talk about the importance of stigmatized language missed in that case. It didn't land, but at least my intentions were in the right place. So let's talk about some of these evidence-based strategies to combat stigma. And the first is my favorite. It's maybe one you've heard before, but maybe I'll give you a little bit of a different twist on it. Because I want to start by thinking about foreign languages. This is, I think, the coolest example in the world. If we were in person and we had any native German speakers and native Spanish speakers, it makes this exercise a whole heck of a lot of fun. But Lara Boroditsky is a researcher at Stanford, and she gathered together a group of native German speakers and a group of native Spanish speakers. And one additional thing, just for context for this study, you know that in English, we don't gender our articles. So if I say the cat, the word the isn't masculine or feminine. But like in Spanish, if I say the cat, el gato, el is a masculine article, right? Okay. So German and Spanish are both languages that that gender their articles. And so this afforded this research team at Stanford the opportunity to do some really kind of obscure, but really creative and interesting research. So they gathered together a group of native German speakers, and they showed them a picture of a key. And I'm going to butcher pronunciations because I am not a native speaker of either of these languages, but the word key in German is something where like der Schlüssel, and der is a masculine article. And so when they asked German speakers, how would you describe this key? The German speakers said it's jagged, rough, hard, heavy, and metal. Pretty masculine terms. Then they showed the exact same picture of the exact same key to a group of Spanish speakers. But in Spanish, the word key is la llave, and la is a feminine article. So when they asked the Spanish speakers to describe the key, they described it quite differently. They described the key as golden and intricate and little and shiny and tiny and lovely. That's a very effeminate description of this key, which doesn't square very well with the very masculinizing description of the key that the Germans gave. They're looking at the same key, you all, right? They're looking at the same key, but somehow they're perceiving reality differently. And then the research team found an example that flips the order. So a bridge. So in German, the word key is, the word bridge is, I don't even know, die Brücke maybe, and die there is a feminine article. So when they asked the German speakers to describe this bridge that they were looking at, the German speakers described it in really effeminate terms. It's beautiful, it's elegant, it's fragile, you all. We have a fragile bridge, it's kind of a problem. And then they show the exact same picture of the exact same bridge to Spanish speakers. But in Spanish, the word bridge is el puente. El is a masculine article. And so if you're following along, because I know you all are critical thinkers, you probably know what's coming next. The Spanish speakers described the bridge in much more masculinizing terms. Big, dangerous, long, strong, sturdy, towering. And so just to drive home this point, I want you to imagine, for the sake of argument, that there's a native German speaker and a native Spanish speaker, and they're standing shoulder to shoulder on the riverbank, all right? And they're looking at this bridge, and one says, I suppose in their native language, that looks sturdy. And the other says, nope, that looks fragile to me. Those are diametrically opposing characterizations of that bridge. How can it be that two people standing shoulder to shoulder, or two people looking at the exact same picture, could perceive reality so differently? And the answer is language. It's because language actually informs our cognitions. It's a phenomenon we call linguistic relativity. If you're interested in diving in, it's kind of fascinating. And if you're wondering what in the heck it has to do with talking about stigma and addiction, it actually has everything to do with stigma, because relativistic language, stigmatized language is most harmful to vulnerable populations. People with substance use disorders. So here's a really cool study that's kind of jumping off of the work that Lara Boroditsky did. So John Kelly runs the Recovery Research Institute out of Harvard or Mass General Hospital, and he created a vignette, a clinical vignette, which is just a hypothetical short story about a man named Mr. Williams. And according to this hypothetical, Mr. Williams is in a drug court program, and he tests positive on his urinalysis. And so the question is posed, what should we do with Mr. Williams? Should we send him to jail, or should we send him to treatment? And if you think about it, that's a pretty realistic scenario that someone, say a probation officer or a judge or someone in community corrections, might face on a regular basis. And they handed out this vignette, they distributed it to at a conference or a summit of mental health professionals. So they're clinicians, they're folks who are trained on addiction and should probably understand it pretty well, right? And all of the vignettes that were handed out were word for word identical, except for one phrase. In half of the vignettes, Mr. Williams was described as a substance abuser who tested positive. And in the other half, he was described as a person with a substance use disorder who tested positive. And word for word, verbatim, everything else about those scenarios were identical. And yet that minor change in language had a profound impact on participants' thinking. So the mental health professionals who received the vignette that said that Mr. Williams is a substance abuser who tested positive were more likely to send him to jail. And the clinicians who received the vignette that said Mr. Williams is a person with a substance use disorder were more likely to suggest that he get an opportunity to treat his disorder. And I love this example for a wide variety of reasons. One is because I'm a millennial. And as such, we take a lot of crap from baby boomers about how we're too politically correct. And there may be some merit to that. I don't know. But this is not about political correctness. What we have every day, I mean, this study is from 2010. What we have now in 2025 is really a mountain of evidence on the impact of destigmatized language. And in this case, it was sort of a mild example of stigmatizing language, right? I don't know. For many of you, you may not recognize substance abuser as even stigmatizing. You can imagine much more offensive terms that people might use, like a junkie or an addict or a crackhead or whatever awful things that people say, a druggie. Um, and so, I like to tell people language matters, and language matters because the way you talk about substance use disorder informs the way you think about substance use disorder, and the way you think about substance use disorder informs the way you're going to treat people who have substance use disorders. And so your language matters not just when you're interacting and interfacing with people who use drugs, where that probably matters to some degree for sure, but it certainly also matters behind the scenes when you're having conversations with your colleagues. When you're sitting with a treatment team and you're talking about a patient, that's perhaps when it matters the most, because that's when that individual is not in the room to be humanized, to be protected. And that's when they're at the greatest risk of really being harmed by stigmatized language, and having, the stigmatized language of providers and of a treatment team actually denigrate the quality of care that they're going to receive, which is exactly what the literature shows, right? So I put this up. You may have seen something like this before. I always want to give the caveat that I am not trying to be like a grammar Nazi. I'm not into finger wagging or telling people what they have to do. This is not to tell you that you're bad if you use the words on the left side of the screen. Like we say, when we know better, we do better. I'm guilty of having said everything on the left side of the screen. But the more that you become familiar with the research, the more you recognize it's low-hanging fruit for being an ally. And it matters in big ways, and it matters in small ways. You notice that I didn't say that Mr. Williams dropped dirty, and that's something we all have been guilty of in my field. If you went and got tested for COVID, your provider wouldn't come back in the room and say, "Well, you're dirty with COVID." I mean, it's so obviously offensive and inappropriate to say that. And the only reason it isn't obviously inappropriate and offensive to say that about someone with a substance use disorder is because SUD is so stigmatized. It should be offensive, right? When people tell me they're 8 years clean, I mean, I'm not, like I said, I'm not a grammar Nazi. So most often the first thing that I say, or the only thing I say, is that's fantastic, great for you. But what I'm thinking in my head is there's no way you're 8 years clean because you were never 8 years dirty to begin with. You know what I mean? You're just a human being. And I know that the first time for many people, when they start using the terms person first language, like person with a substance use disorder in lieu of addict, there are a lot more syllables there. And so it feels clunky the first time, first 10 times, first 100 times. Take my word for it. When you practice this, it becomes a regular part of your language, and it does a number of things. One of the things it does is really put a spotlight on stigmatized language. Now, I used to use the word addict all the time. And now when I hear the word addict, I physically feel a little cringe because I know what it connotes. I tell, when our staff leave Voices of Hope and they want to go get a job somewhere else in the community, which we always want to see our peers move up and move on. I tell them, don't go tell your prospective employer that you're an ex-addict. Don't go tell them that you're a recovering addict. Don't go tell them that you're a ex-abuser. Tell them you're a person in recovery, because all of the literature shows that it's going to make a systematic difference in your ability to get that job. Since we have just a minute still available here, I just want to mention this. It's kind of a joke, but it's also serious. One of the reasons I don't like the term drug abuse is because I really think it's misleading for a variety of reasons. One, it's very stigmatizing because the word abuse connotes some kind of violence. we associate child abuse, domestic abuse, right? I mean, kind of immediately that connotes something violent. And as I said before, there is a relationship between drug use and violence, but we need to be really careful to parse that out accurately so that we don't perpetuate stigma. And so when people say, drug abuser, I like to remind them that really I wasn't an abuser of drugs. In fact, to be honest with you, I kept my heroin in a very special box where I also kept my rigs and my syringes and my ties. And that sounds like I'm making a joke, but I'm being serious. I never abused my drugs. I took very good care of my drugs. So it's misleading terminology, it's stigmatizing terminology, and it's just kind of obsolete. So we're moving ahead. So you may have heard language before. Sometimes I think I don't want to say this to invalidate everything I just shared. So let me first say language is low-hanging fruit, and we all need to practice it as best we can. Having said that, that's not going to be the only way that we root out stigma. And sometimes I get the sense that it's sort of like the only crutch that we're leaning on to do a lot of our stigma reduction work. And really, as I told you, the most effective strategies, specifically among healthcare providers to reduce stigma, are contact-based strategies. And so I want to share two really good examples of that. The first comes from Dr. Carl Hart, who you all may know. He's he's a neuropsychopharmacologist, I think it is. He was like the former chair of the Department of Psychiatry at Columbia. He's identifies as a person who uses drugs. And it's really powerful. He wrote a book recently called Drug Use for Grownups, Chasing Liberty in the Land of Fear. And that's a part of the thesis of the book is that really, especially when you consider alcohol a drug, which indeed it is, the National Survey on Drug Use and Health shows that the overwhelming majority of Americans use drugs. Like 60-some% of US adults use drugs. And so the whole notion that drugs are bad is so misleading and so stigmatizing. And part of what Carl Hart's pointing out is one of the ways we're gonna effectively destigmatize substance use disorder is by destigmatizing substance use in the first place. And the way that he does that is by standing up and shouting out loud, I'm a professor, I'm an academic, I'm a family member, and I'm a person who uses drugs. And that's a really powerful way to make that statement. Another example of that would be Maya Sislovitz, who just wrote an op-ed in the New York Times about the title. I'm paraphrasing, but the title was something to the effect of, I'm in addiction recovery and I still drink wine, or something like that. And again, really doing a powerful job of a contact-based strategy, using her lived experience to shape a new narrative around other stigmatized pathways of recovery, like the 40% of people in recovery who continue to use substances, which shocks a lot of people, but that's part of the reason why the obsession with abstinence becomes so problematic. My single favorite example of a contact-based strategy came from Clemson. And when I went to Clemson to speak, I was calling it Clemson because that's how it's spelled, but everybody there told me that it's pronounced Clemson, as if there's a hidden P in there somewhere. So that's just for you to know. And I went to the conference, I presented my session on some research I was working on, and I saw that one of the other sessions was on medications for opioid use disorder. And I know many of you all are well aware of the stigma in particular that surrounds that pathway of recovery. And so I always treat that with particular interest. I was interested to see, how is this speaker going to handle it? How are they going to address it? How successful will they be, you know? And to be honest with you, he did a really underwhelming job. It was really academic. He reported all of the updated literature and all the most recent studies, but it wasn't very compelling. It was just kind of a data dump. And I was kind of disappointed. And then just as he put up his like references slide, he was just about to leave the podium. And then he said, oh yeah, one more thing. And he put up one more slide, and his very last picture was a picture of him like this. And I don't know if you all can see me on camera. It was a picture of him putting his buprenorphine strip on his tongue that morning. Because what he didn't tell us until the very end of the presentation was that he wasn't just an MOUD researcher and an academic, but he was also a person who used MOUD as a part of their recovery. And I don't remember a single statistic that he listed off about reductions in mortality or whatever it was, but I will never, ever forget that moment. I'll never forget the audience's reaction. And I went up to him afterwards. I waited in a long line to go speak to him afterwards to tell him that. And I thought it was the single most brilliant thing that I've ever seen. And so it's that constant reminder to me that I get to do a lot of advocacy and a lot of speaking and a lot of research, and all of those things have a role to play in reducing stigma. But whether I like it or not, my lived experience, my story, my recovery, in some ways is just the most powerful way to reduce stigma. And we're coming kind of close to our end of time, and I want to be sure to leave a few minutes for questions. But in the event that we have any folks on the call who are themselves peer support providers, or certainly any clinicians who are working on treatment teams with peer providers, I wanted to talk about the stigma that peers experience, because for a variety of reasons, they really exist at this really vulnerable intersection. So real quick background: peer workers, peer support specialists, peer mentors, sometimes they're called alumni advisors, if it's more like a therapeutic community or a residential treatment center. But they're peers, they're people with lived experience. And, they're kind of periprofessional. And the increasing burden for substance use disorder drove the need for peer support. And I mentioned that for a specific reason. I mentioned that because peers play a very specific role. And that role is not to be a junior therapist or a less trained therapist. They're not like a sponsor. They're not drug and alcohol counselors. They're not clergy. They're not, kind of like a nurse, but less educated. They're not any of those things. They're peers. And they're intended to play the role of advocates, of motivators, of outreach workers. And yet so often they're viewed as sort of clinical, like diet clinicians, like clinicians, but less than. And they are absolutely not. They are really playing a very specific role that helps bridge the gap between treatment teams and people who use drugs. Because of their lived experience, they develop a rapport much more quickly. But what it means is they're also asked to code switch, right? They're asked to code switch in the sense of when they're talking um, to the participants they're working with, they have to be able to talk the language of the street, basically, right? They have to be able to talk kind of in a parlance or a nomenclature that speaks to that audience, and then they have to walk right out of that interaction into an interaction with a healthcare team who doesn't want to hear an F-bomb and who wants to hear, clinically informed language. And that's really challenging, and it puts them in a tight spot. And so we did some research really regarding protecting the role of peer support specialists and protecting their integrity. We published in 23, 24. And one of the things that the literature shows is that we need to do a good job of explaining to treatment providers specifically who peers are. And so, yeah, we obviously need to do a good job of focusing on training peers to equip them with all the skills that they need for trauma-informed care and building an alliance and all those things. But we also have to train treatment teams, because more and more, increasingly so, we're seeing peers introduced into behavioral health settings where treatment providers, and I mean no offense to any of you all, because of course you shouldn't know. How could you know? You don't know how to interact and how to work with these folks on a treatment team. You sort of have a sense that they have a role to play, but often don't know what that role is. And so when we asked peers what tasks they performed, participants reported being asked to do everything from the case management jobs to the admin jobs to being the janitor to being the case manager to peer support, literally everything. Asked to do everything with little pay, always the lowest paid person in the building, always asked to be the one to take out the trash, to pick up the cigarette butts outside, while other people basically weren't doing anything. That's kind of what we had to deal with. And she was literally not the only one who mentioned cleaning out trash cans, and neither was the second participant. We had a third participant in a qualitative study of 25 who mentioned who mentioned taking out the trash. It's an example of the way that treatment teams have misunderstood the role of peers, and they think, this is a less trained clinician, so it's just someone we can have do the lowest on the totem pole jobs. And participants in our study identified a dissonance in their role as peers, being a non-professional, kind of egalitarian, on equal footing with the folks they serve, and then also being a professional and how to be socialized to the workplace. So for instance, many peer support specialists have never been taught how to send an email. And so a lot of our peers at Voices of Hope, when they first get onboarded, they send really terse, sometimes outright offensive emails. And it's not because they're stupid. It's not because they're incompetent. It's because they haven't been socialized. They haven't had the benefit of being socialized to a professional environment the way that I have. And so that's a part of working with peers, and a part of managing, reducing stigma is being able to manage those expectations and understanding who peers are and the role that they're supposed to play. So another way someone else put it was, the biggest issue they have with me is professionalism. They teeter-totter me. Yeah, you need to do your job. Yes, you need to be you. Yes, you need to share your experience, strength, and hope, but now you need to be a professional. Um, and another person said, I never had a job in the corporate world, in an office setting, those kinds of things. So I had to curb myself into that lifestyle. So we really um, underscore the importance of offering trainings for the role of peer supports, not just for peers, but for treatment providers at large. And then finally, last thing I wanted to address, and then take any questions that you might have, is a question that someone posed beforehand that was such a good question. And it was such a good question that I thought about it and digested it and want to answer it myself. But I also sent it to our HR manager at Voices of Hope, because she has now been for about a decade in charge of about 80 staff, all in recovery. She's one of the biggest employers of people in recovery, so in the state of Kentucky at least. So she has a lot of direct experience with this. And so this excellent question that someone asked was, how do you address stigma in the workplace? What about when you have a complicated hierarchy and you're concerned about kind of blowback for trying to stand up for yourself? And so this is just word for word what Marisha Brown, our HR manager, had to say. She said, stigma, whether it be substance use, mental health, or something else, only serves to break down a work culture and detract from progress. Obviously, culture can vary from workplace to workplace, but it's best addressed through education and open communication. And I highlighted the important words for you guys in bold, okay? In our workplace, we started educating people from day one on reducing stigma and the importance of our word choices. And let me pause there to also mention that I do the same for my courses. The courses I teach at UK, I teach a course, for instance, in the honors college called Addictions and Chronic Disorder. And on the very first day of class, we do a free association exercise to learn a little bit about implicit bias with addiction and recovery. And then we talk about language. And I tell them, look, you're going to screw it up all year long. I'm not going to take off points for using destigmatized language. That's not the point, but I'm going to check you every single time. It's going to give you the entire year to really practice making that a normalized part of what you do. And so we do the same with our staff when we onboard them. We also continue to offer educational opportunities for managers on how to provide support, to take a supportive management approach, and being aware of our employee assistance program, time off policies, et cetera. So for instance, most of our folks are not just in recovery, but most of them are fairly early in recovery. I don't know if it's maybe even stigmatizing to suggest that many of them are in a precarious, part of their recovery where statistically they're subject to potential relapse. And for that reason, we take things like mental health very seriously. And so our managers are really well trained in all the permissiveness of our time off policies, so that when someone needs a mental health day, they aren't treated unfairly for exercising that right within our organization. With many of our management in recovery, they're aware of the support many people need. And the pitfalls of stigma. We also maintain policies that promote civil and professional conduct and maintain an anti-harassment policy. While we encourage staff to discuss matters with their managers directly and privately, employees always have the option of speaking directly to HR. And then she went on to say, if you work for another company, I would first ask about your comfort level speaking directly to your manager or to this individual privately. Handling things directly, privately, and at the lowest level first is always the best option. Many times people don't realize that they're being stigmatizing, very true, and confronting someone openly or jumping all over them without giving them the chance to correct themselves can only serve to make matters worse. Also very true. And so I want to jump off of this. I know it's time to take questions, just by saying, I have a colleague who likes to remind me that sometimes when we're talking about stigma, particularly in the context of something like the workplace or school or any type of a setting where some legal protections might take place, substance use disorders covered under the ADA, that really means for us that stigma and substance use disorder are not what am I trying to say? That stigma in the workplace is discrimination. That's the word I'm looking for. So often we use the word stigma, and what we actually mean is legal discrimination, people being discriminated simply because they're in recovery from a substance use disorder. So much more to say about stigma. I know that we need to stop there just for time. Can I take any questions now, or offer my email to you as well to take questions that way?
You can go to the links or use your phone to do the QR codes. And I will pull up some of the questions we received in the Q&A.
I just want, are you guys seeing the slide? I just want to make sure it's.
No, maybe.
Oh.
Oh, I'm seeing my slide. Yeah.
Oh, okay.
Yeah.
But maybe stop sharing just to be safe, Alex. Thank you.
Okay.
I had this happen before where
Got it.
I thought I was sharing and so.
I can see your slides there.
Yeah.
Okay, good. Thank you.
Okay, so some of, let me see. So fellow Wildcat here, someone says, how do you address the use of stigmatizing language by clients about themselves? Sometimes they seem to be more familiar with terms like drop dirty and equate inclusive language with being clinical.
Yeah, and that's a really good point. And it's why I mentioned I don't want to be finger wagging, because for instance, sometimes after we talk about language, somebody in recovery who's a member of a 12-step program will come up and say, "Hey, I'm a member of a program where we identify as an alcoholic. Are you telling me to go into my next AA meeting and say I'm a person in recovery?" And so first of all, I'm absolutely not. Absolutely not. When you go to a guest's house, you respect the rules of their house, right? We respect the traditions of that program when we're there. And we're also we're somewhat less concerned about stigma in that context because that's in group. However, we are concerned about stigma when we're public facing. So that's more of a concern. We have, a considerable amount of literature that shows that kind of internalized stigma, self-stigma, can be harmful. But we also have not just published literature, but just also from our personal experience, lots of people who tell us essentially what your question is intimating, which is people on experiencing homelessness who are IV drug users might not identify as a person with a substance use disorder, right? In fact, it's incredibly unlikely that they will. So your choice to use that language, you could continue to model it for them, despite them using a different language. If they seem off-put by it, or it seems to be creating a problem in terms of communication, I would definitely tell you to prioritize your relationship with them rather than this language. But that's a really good question to get down into the nuance. So thank you for that.
Yeah, and actually a couple of the questions were kind of along the same route, especially with the AA. Do you think that destigmatizing language can go too far? So for example, instead of saying positive, being told to say non-negative, while language is always being updated with current events, new meanings, etc., can it become more detrimental at some point to consistently change what words we are using?
Yeah, in fact, I think we just heard our own governor in Kentucky say something to that effect recently, that using language like substance use disorder, while it means a lot to academics and clinicians, it might be excluding a lot of people. And so I go back and forth. I know a lot of people just became familiar with using the language of medication-assisted treatment. And so when we started talking about medications for opioid use disorder, it kind of makes them go, like, and I get it, but also medication-assisted treatment is misleading and it is stigmatizing. It suggests that medication's assisting the treatment, and it's not. The medication is the treatment. So I think, in short, yes, this can be turned into political correctness and it can go too far. But in most cases, what I see is we're basing it on the science and basing it on the literature, and really just trying to open more doors, trying to reduce the amount of social discredit that people are experiencing.
I think we got time for one more. So in training and school for therapy, there has always been this notion of self-disclosure is helpful, but to tread carefully. When it comes to self-disclosure related to substance use history that is intended to destigmatize, do you have any insights on how best to share your personal story with clients?
Such a great question. I was working on a grant proposal this morning, and one of my colleagues was asking that question: do you ever disclose that you have lived experience in your grant proposals? And I definitely do, because fortunately, a lot of funders more recently have recognized the importance of people with lived experience. But we have another colleague on the project who is also in recovery, but she's not open about it. I know this, no one else knows it, except for one of our other collaborators. And so she was asking me, should she mention it? And I'm like, well, first of all, you need to go to her and ask, because she may not want to be outed in that way. There was actually, I just saw on my Google Scholar, a study published maybe 2 weeks ago that was about academics self-disclosing in recovery. And so all of that to say, it is fraught with precarity. And in some ways, because of my privilege, it's a bulwark against some of the ways that I would be socially discredited for coming out publicly. But you should know that it isn't all butterflies and rainbows, and absolutely, you put yourself at risk even in those settings. And that's why anytime someone's willing to do it, I do see it as a courageous act.
And with that, we are at 1 o'clock. So thank you again, Dr. Ellswick, for a wonderful presentation. Thank you for being here with us today. We really appreciate it.
Thank you.
And as a reminder for everyone, we will be sending out the CE information. So if you did not get it, you will get an email with that. And thank you for everyone for joining us, and have a good rest of your day.